Our next session is our emerging practice and research abstract session. So this will be rapid speed going through 5 different talks, and each talk is about 8 to 10 minutes. It's been pre-recorded. We will play that for you, and then we ask that anyone with questions type your questions into the Q&A section. You can find that either at the bottom or top of your screen. And if you wouldn't mind putting the first name of the presenter before your question so that each presenter knows that the question was directed to them. I'm going to put a little thing in the chat too, so you have a list of their names handy just in case you forget. And we should have about 10 to 15 minutes at the end of this session for live Q&A, and we'll earmark a few of your questions for that live session. But all others will have the presenters do typed responses into the answer field. So we'll see how this goes. Hopefully it goes well. And then if we hit any snags along the way, we'll do some course correction. All right, so our first speaker is Nalani Thomas, and she will be presenting on addressing perinatal mental health with a diverse workforce in Arizona, a policy brief.
Hello, my name is Nalani Thomas, and I am a first-year doctoral student in the Population Health Program at ASU. And today I will be presenting a policy brief on addressing perinatal mental health with a diverse workforce in Arizona. The emergence of this policy brief was in collaboration with Dr. Jenny Beaver of 4th Trimester Arizona. Additionally, we would like to acknowledge Elizabeth Wood and Delana Cuthbert of Postpartum Support International for their invaluable guidance and suggestions. Our learning objective today is to be able to define and note the gaps in perinatal mental health care, understand the current state of perinatal mental health policy at the federal and local level, and to discuss recommendations to improve perinatal mental health provider diversity and access to care. So what is perinatal mental health? Perinatal mental health are conditions that it's an umbrella term that encompasses a variety of mood disorders whose onset is associated with pregnancy. And so some of these diagnoses include depression, anxiety, and psychosis. In the United States, an estimate of 20% of pregnant women will experience perinatal mental health conditions. And of those women, about 50 to 75% will never seek treatment. When we look at individual diagnoses like perinatal depression, 1 in 7 women will experience that within their first year of motherhood. And then for postpartum anxiety, about 20% of pregnant women will experience that. And of co-occurring both perinatal anxiety and perinatal depression, about 10 to 50% of women experience co-occurring diagnoses. In Arizona, almost half of pregnancy-associated deaths were attributed to a combination of mental health and substance use disorders. Furthermore, American Indian and Alaska Native women in Arizona demonstrated to have a disproportionate outcome related to maternal mortality, with them experiencing twice as many deaths or perinatal mental health related deaths when compared to live births. As a result, this demonstrates that there's some considerable gaps in care that are quite cyclical in nature, looking at workforce availability, workforce diversity, and continuity of care. So for workforce availability, Arizona is ranked 47th in availability of a mental health workforce and meets about 8.54% of its mental health care needs in the state. As for workforce diversity, less than 16% of psychologists and practicing psychiatrists in the United States identify as racial or ethnic minorities. And for continuity of care, from what we're learning in the literature, there's evidence that patient-provider concordance has improved utilization and accessing mental health care providers among Black, Indigenous people of color. So best practices for screening for perinatal mental health conditions is paramount during prenatal visits. And as you can see in this map, The United States is experiencing a severe desert for general maternal care. And this is concerning because screening is so critical for prevention and early detection. When we look at it from a local level, we can see the care gap distribution. So, when comparing the distribution of live births and perinatal mental health related deaths in Arizona from 2016 to 2018, a large amount of both live births and deaths were occurring in central Arizona, so where Maricopa County is. But when you look at the other regions, you can see that the disparity is quite clear with the southeastern, northern, and western regions, the remaining regions in Arizona, experiencing more perinatal mental health pregnancy associated deaths than they're experiencing live births within that region. And this is actually interesting to see, especially when you compare it to the distribution of perinatal mental health certified providers in the state. So this is the comparison to the distribution of certified perinatal mental health providers in Arizona by county. And so it's clear that Arizona is a desert in more than one way. In this visual, you can see that the counties in dark red have no perinatal mental health certified providers. That's 8 counties without providers specialized in perinatal mental health. And of the counties that do have a certified perinatal mental health provider, their caseloads are quite sizable, going from one provider to 250 patients a year, or one provider for more than 500 patients a year. So this only reiterates the gap in workforce availability that is happening across the state. And so this image is very jarring, especially when we're comparing it to the distribution of live births of perinatal mental health deaths related by region, because it shows that there's a clear opportunity to improve network adequacy for care. So, over the last few years, there's been increased momentum in generating awareness for maternal health disparities and mental health outcomes. And some of these efforts include funding for more research about diversifying the perinatal mental health workforce and the formation of an interagency task force dedicated to quality improvement and best practices for perinatal mental health. And fortunately, in Arizona, there's been some progress made in addressing perinatal mental health and diversifying the workforce, with ADHS providing full scholarships for mental health care providers to become perinatal mental health certified through PSI. Additionally, recent Arizona law passed requiring continuing education credits for behavioral health providers that are related to ethics, cultural competency, and diversity. Additionally, there's been increased community and local efforts with the founding of Black Therapists in Arizona in 2021 and the great work of PSI in engaging BIPOC mental health providers in the perinatal mental health space. As for recommendations going forward, they align with the report published in 2022 from the Maternal Mental Health Advisory Commission report of recommendations, which in summary is underpinned by 2 broad concepts of collaboration and implementation to practice. Collaboration is recommended at the community level and through multi agency support in order to bolster and build diversity in perinatal mental health providers. Implementation to practice recommendations are concentrated in recruiting and retaining providers and better data to understand network adequacy and the current racial diversity in perinatal mental health providers. Also, the recommendation is to create, disseminate, and implement culturally relevant curriculum that is geared towards early detection and monitoring of perinatal mental health conditions, and increase funding to support crucial changes needed to improve maternal mental health outcomes in Arizona. So this is the conclusion of my presentation, and I thank you all so much for your time.
Thank you for that presentation, Nalani. Our next speaker will be Elizabeth Williams. She'll be speaking about staff perceptions of transitioning to telehealth for home visitation program.
Hello, everyone, and welcome. My name is Nalani Thomas, and I'm a first-year doctoral student in the Population Health program at ASU.
My name is Elizabeth Williams, and I'm a second-year doctoral student in the Population Health program.
My name is Abdullah Verk, and I'm an undergraduate majoring in biomedical sciences.
And we are presenting on staff perceptions of transitioning to telehealth for a home visitation program to support fragile infants due to the COVID-19 pandemic. In 2019, over 6,000 babies in Arizona were admitted to the NICU post-birth. And as we know, 2020 was the beginning of the COVID-19 pandemic, which resulted in rapid transitions faced by programs, especially programs with home visitation, in order to adhere to social distancing and stay-at-home orders. We had previously conducted a quantitative study as a natural experiment design to understand the differences in telehealth and in-person visitation for program effectiveness for a home visitation program. We found that in-person and telehealth visits were just as effective in meeting the needs of families with fragile infants. As a result, today's presentation is a qualitative study that is an extension of our previous work in order to gain contextual understanding of these findings from our previous approach. Our aim for this current work was to address or to compare the experiences of staff who transitioned from in-person to telehealth and telehealth to in-person visits for case management of babies that had graduated from the NICU. For methods, we used the rapid qualitative analysis approach and based our coding on the modified technology acceptance model and used that as our theoretical framework. We deductively coded and created themes based on illustrative quotes from the a priori domains of this theoretical framework, which are perceived usefulness, perceived ease of use, and intention to use. We conducted interviews January 2022 to December 2022, and interviews lasted anywhere between 30 to 60 minutes. Overall, we had 6 participants. 3 participants were in-person to telehealth staff, and 3 participants were telehealth to in-person staff. We also had 3 follow-up interviews that were conducted, and they were with our in-person to telehealth staff members. We coded the themes based on the theoretical framework and came up with 4 broad categories. These categories are staff-centric, family-centric, technology-focused, and collective adjustment. Staff-centric themes focused on staff's perception of their own effectiveness to perform their job function. So while staff-centric themes are closely aligned with family-centric themes, what makes it different is that practical adjustments that happened or that staff included in order to perform their job function. And so in this theme, or in this category, there are a lot of themes that were focused on being able to serve a greater number of family outside of their service areas and adjusting their time management from not driving anymore. There also were themes that were related to warm handoffs with external providers, so being able to connect families with greater amounts of services in a more convenient way.
While this study did not interview any families directly about their experiences transitioning into a telehealth model of home visitation service delivery, staff often referred to the benefits and challenges that families experienced. Overall, staff repeatedly acknowledged that their families consistently continued to remain engaged with telehealth services and accomplished this by leaning into their own strengths and resiliencies. Themes in this family-centric category included parent challenges and resiliencies, adapting communications, individualized family support, and soliciting family feedback.
The technology themes that were identified during these interviews focused on the challenges of providing care using digital means. The interviews highlighted that both the staff and families were not familiar with Zoom and other websites or applications such as DocuSign. As a result, agency support was valued at this time and allowed everyone to learn how to use certain features and also allowed the staff to optimize online care. However, by entering into the online space, concerns about maintaining client confidentiality arose amongst the staff. Choosing Zoom and other reliable platforms to provide care enabled providers to be more comfortable giving care in an environment they knew was safe. The collective adjustment themes focused on the growing pains of adjusting to change from both families and providers. Due to the pandemic, staff and families shared vulnerability and fears, and that emotional connection that formed helped guide their collective adjustment. It also helped build stronger staff-client relationships. The new mode of communication required a learning curve, but in the end, everyone felt that telehealth was just as, if not more effective than in-person care. In this study, the first limitation is that there was a small sample size of 6 participants. This can be attributed to the fact that the program does not hire that many staff. However, it should be considered since it can still affect the generalizability of the results. Another limitation is the lack of non-female perspective amongst the participants. In addition, the staff turnover limits institutional memory. And lastly, COVID-19 restrictions that applied to the study are not fully applicable to modern day practices.
Have identified a number of benefits for the transition of home visitation to telehealth service delivery. Staff highlighted the value of telehealth in allowing them to extend the geographical range of their services and their new ability to see families across the state of Arizona, rather than limiting their visitation to drivable distance in the Metro Phoenix area. Staff also highlighted the ease of incorporating outside referrals into telehealth visits, since other service providers could simply join the telehealth appointment. This lessened the burden on families who had to juggle multiple appointments with their fragile infants. Staff also highlighted the benefit of telehealth by protecting fragile infants from exposure to illness. This included not just COVID-19, but also colds and flus. Staff identified an initial challenge of demonstrating physical skills on an infant, but these were quickly overcome by the use of innovative tools, such as utilizing a baby doll to help parents understand the physical positioning that the staff hoped to see in their infant. Staff did occasionally mention desire to have in-person visits, but only sporadically and only with specific families that they felt would truly benefit from in-person supports. Staff discussed the importance of providing individualized support for each family on their caseload, and felt that telehealth provided the opportunity for flexibility and individualization of service delivery to best meet the needs of each family and infant. As a global disruptor, COVID-19 accelerated the adoption of technology in the workplace. This meant some of the aspects of our theoretical framework felt outdated. While the technology acceptance model encapsulates the general experiences of our interviewed staff members, there were some clear deviations, specifically challenges to the intention to use domain. Because of the hastened transition to technology due to the stay-at-home orders, staff did not have the option to not use telehealth in order to continue their home visitation program. In the future, the technology acceptance model framework could benefit from adaptations that address the rapid adoption of technology due to large global disruptors such as COVID-19. In conclusion, from a staff perspective, there was not a difference in their job effectiveness, providing services, or building rapport with families between in-person and telehealth service delivery models. This indicates that telehealth is an effective mode of delivery for home visitation programs. Thank you. We welcome any questions.
Thank you, Elizabeth and colleagues. Our next presenter will be Kiara Lyons, and she'll be talking about the prevalence and measurement of adverse childhood experiences among children and adolescents. As a reminder, don't forget to post your questions in the chat using the speaker's first name before your question.
Good afternoon, everyone, and thank you for joining me today for my presentation titled Prevalence and Measurement of Adverse Childhood Experiences Among Children and Adolescents in the U.S., a scoping review. So a couple disclaimers before we begin. The information within this presentation is the work of my own and does not necessarily reflect the views or positions of ASU or any entities they represent. I also do not have any financial disclosures. So our overview of this presentation, I will first talk about the background of ACEs and identify knowledge gaps that led to this research. I will then go into discussing the aim, research questions, as well as the methods and results of this project. And then I will end with the conclusions and public health implications of this work. So ACEs background and knowledge gaps. So adverse childhood experiences, also known as ACEs, are defined as a traumatic experience that occurs in a person's life before the age of 18 years. This term was coined by the ACE study, which was conducted by CDC and Kaiser Permanente back in 1995 and 1997. And they linked ACEs such as abuse, neglect, and household dysfunction to many negative health outcomes later on in life, including chronic illness. Now, when looking at ACE prevalence, the Behavioral Risk Factor Surveillance System, also known as BREVIS, mentioned in their 2019 report that 61% of adults experience at least one ACE. They also said that 1 in 6 adults experience 4 or more ACEs. Now, when looking at the impact of ACEs for adults with 4 or more ACEs, they found that adjusted odds ratio ranged from 1.4 for cancer to 5.3 for depression. Now, since the original ACE study, ACEs research has been conducted in primarily 3 areas: retrospective survey research, clinical assessment of ACEs, and cross-sectional survey research. Now, retrospective survey research is adult-focused, and it looks at their childhood experiences. Examples of this would be the ACE questionnaire or BREVIS. However, limitation with this is that it's not child-centered, and there's usually a major concern for recall bias. For clinical assessment of ACEs, this can either be child or adult focused. However, this type of research tends to focus on a specific population, meaning that there's usually a smaller sample size, which means also that you lack generalizability. And for the third area, cross-sectional survey research, this can also be child or adult focused, but it's usually often population-based. And a major limitation is that it cannot establish causal and effect relationship. So this leads into the knowledge gaps. Now, based on the literature, prevalence of ACEs varies widely based on the assessment tool that's being used, populations being studied, and the settings. Additionally, there is no commonly agreed upon methodology approach for measuring ACEs, specifically among children and adolescents. So that leads us into the aim and research questions. So the aim of this study was to examine what methodological approaches have been used to determine the ACE prevalence among those under the age of 18 years in the US and investigate the prevalence of different ACEs among that population. Our research questions were: what methodological approaches have been used to determine ACE prevalence? Specifically, how were ACEs defined? What type of assessment tool was used? What age group and settings were focused on? And then what evidence supports the different methodological approaches? The second research question was, what is the prevalence of different ACEs? So now we get into our methods. So for this study, we conducted a scoping review, and the inclusion and exclusion criteria are as follows. We included articles that were English-based and in US-based, and they were focusing on individuals under the age of 18 years. We also focused on articles that highlight the screening and surveillance of ACEs and or looked at the evaluation of psychometric properties of ACEs screening tools. Now we're looking at the exclusion criteria, articles that focus on diagnosing persons with mental illness, looking at adults and their childhood experiences, so a retrospective survey research, intervention-based studies, and focusing on ACE-related outcomes rather than ACE prevalence were excluded from this analysis. We utilize data sources such as PubMed, Embase, CINAHL, and PsycInfo, and we use a time frame of 2009 to 2020 for this scoping review. In accordance with this, we conducted an abstract and full text review. So now we'll get into some results. So a little overview of some of the results highlighting the methodology and prevalence behind the articles included in this analysis. There were 27 articles that we had included in the final analysis of the scoping review. Within those, we found 26 unique instruments that were being used, some studies even utilizing multiple instruments. Now, the questionnaires range from 5 to 80 items, and the settings also ranged from national sample to school, clinical, or even a combination of these settings. One study even also looked at the juvenile correction facility. When looking at prevalence reporting, the type of prevalence reporting also varies. Some will provide lifetime prevalence, some will look at the past 2 months or past year. We also noticed that there were several articles that actually did not provide a time frame for the prevalence that they were reporting. And then prevalence reporting was reported as either a mean score, so the average number of ACEs that that individual had, individual, or a cumulative score. So either like 1, 2, or 3 or more ACEs. So this table is important because it highlights some of the very important key findings regarding methodology behind ACEs research. And so what we did, we highlight these major findings and then also provide recommendations in response to those findings. So when you're looking at ACEs definitions, we noticed that ACEs definitions were not standardized. In our recommendation was that standardized conceptualization, definitions, and operationalization of ACE categories is needed to create a more uniform and comparable measurements. The second major finding was that many instruments are used to measure ACEs. So although we do not believe there's a one-size-fits-all approach to measuring ACEs, we do believe careful consideration should be taken into justifying what tools you are selecting to measure ACEs among a certain population. And the justification should go beyond just evaluating psychometric properties. And along the same line of psychometrics, the studies included in this analysis showed good reliability and acceptable validity. However, just like with ACEs definition, we did not see a standard method that was used for instrument evaluation. So our recommendation was that the standard approach was needed, especially because we were noticing a lot of the research was not evaluating the same type of reliability or the same type of validity. In addition, it's important for researchers to emphasize that just because a survey is found to be reliable or valid, that does not mean it's appropriate. For the next finding, we saw that ACE prevalence varied widely among different studies. So this can be depending on the setting, the participant's age, or even the reporting type. So if it's a self-reporting tool, caregiver, or clinical reporting tool, that should be emphasized when conducting this type of research. And then also clearly state and support the timeframes used to examine ACE prevalence. So are you looking at lifetime prevalence, or are you looking at prevalence over a specific period of time? And then the last major finding was that when you're looking at subgroup analysis, so if you're looking at age, gender, race, ethnicity, care should be taken to ensure adequate sample size is there for statistical significance based on the plan analyses. And also we noticed that some of the articles included the term gender in regards to what they were going to assess. And when you're looking at the results, they actually were just looking at just male and female. So if you're going to use the term gender, be more inclusive of gender identity. So although there were some important findings with this research, it does not go without limitations. So when looking at the eligibility criteria, we only focus on US-based articles and articles published since 2009, which resulted in a smaller pool of articles. Also, the study does not address important topics such as the timing, frequency, or duration of ACE exposure among children and adolescents. However, we were able to still highlight some important public health implications regarding the measurement of ACEs and identify some key themes and patterns that have influenced the various ways in which ACEs are reported. That leads into the public health implications. So conclusions were the expansion of ACEs and ACEs research called for an understanding of methodological approaches used to appropriately measure ACEs and improve how we address them. How ACEs are measured influences the reporting and interpretation of ACE prevalence, as well as play a key role in implementation of ACE-related interventions. Now, strengthening the methodology of ACEs research is needed to advance the field, and that starts with standardizing and operationalizing ACEs. And as a public health implication, a review of ACEs literature helped highlight the importance of conducting appropriate surveillance, as many factors contribute to variations of ACE prevalence estimations. And that is the end of my presentation. Thank you.
Thank you, Kiara. We'll move on to our next speaker, who is Bree Van Dyke. She'll be talking about embracing our scars related to self-harm.
Hi, my name is Bree Van Dyke. I'm an LCSW at UCLA Santa Monica, and the title of my presentation is Embracing Our Scars Self-Harm 101. I'm just going to run through some of these slides here, the ones that are going to be most relevant for this time slot. So, what is self-harm? Non-suicidal self-injury is a